Namaskar. A warm welcome to all of you. Thank you for joining us today for this vital and timely webinar on heart disease in the new world and challenges ahead. I am Vanna Chawla and I am honored to be the moderator for today's session. As we know, cardiovascular diseases are no longer just the concern of the elderly. With changing lifestyles, increasing stress, and sedentary habits, heart disease has emerged as a major public health concern across all age groups. Today, our esteemed panel of healthcare experts will help us unpack the rising burden of heart diseases in the modern era, risk and effective strategies for prevention and management, the looming cardio-renal metabolic tsunami, and what lies ahead. Let me take a moment to introduce our distinguished panel. We have Dr. Shuchin Bajaj, a visionary healthcare leader, founder, and director, Ujala Cygnus Health Hour, and our keynote speaker for today's session. Dr. Sundeep Mishra, renowned cardiologist and chairman, Cardiac Sciences, Ujala Cygnus Group of Hospitals. Dr. Bhawani Shankar, Chief Interventional Cardiologist, Ujala Cygnus Super Speciality Hospital, Kaithal. Dr. Rajay Narain, a global voice on cardiometabolic and preventive cardiology. He is an honorary cardiologist at St. George University Hospital, London. He is founder, director of Global Health Alliance UK. He has set up the UK's first cardiometabolic clinic in the NHS London, which looks after complex heart diabetes and kidney patients together in a common setting. Dr. Shamit Gupta, Medical Director and Critical Care Specialist, Amrit Dhara Mile Hospital, a unit of Ujala Cygnus Healthcare, Karnal. Dr. H.S. Bhandari, well-known senior consultant nephrologist, Ujala Cygnus Central Hospital, Bhandari. All the esteemed speakers, we are deeply grateful for your time and presence today. Without further ado, it's my pleasure to invite Dr. Shuchin Bajaj to deliver the keynote address and set the stage for today's discussions. Over to you, Dr. Bajaj.
Thank you very much, Dr. Vanna, and once again, thank you for having this eclectic panel of experts on your platform. It's always very inspiring set of people that you managed to get together, and today having Dr. Rajay Narain, I think biggest of all, very dear old friend and a mentor that I have always looked up to for a long time, on the same panel as Dr. Bhawani and Dr. Sundeep Mishra and Dr. Bhandari and all of us here. I think it's a great experience to have all of us. We all understand truly that, as you said, there is a new phase of heart disease that we are looking at these days. It is no longer a disease of affluence. The disease is hitting younger people, poorer people, and rural population more than ever. And India, it is accounting for almost 28 to 30% of all our deaths, with a growing burden on low and middle income population. And the average age of the first heart attack in India is almost 10 years younger than in the West. So we really need to think of why this lifestyle paradox is there, We keep blaming the West for an unhealthy lifestyle and keep praising our traditional methods. But what has unfortunately happened is that urbanization and processed diets have really introduced sedentary behavior, fast food, and chronic stress into our previously low-risk populations. And one factor that we all overlook, especially in North India where we all live, is air pollution, which is a huge major contributor now to cardiovascular morbidity. What we see every year happening in the entire Indo-Gangetic plain, right from Pakistan's Lahore to Banaras, all across the cow belt, as we call it, is a haze of pollution that hangs over our heads for 3 to 4 months at a stretch. Even today, I have this pollution index on my watch every time. Even today, I think the AQI in Delhi is almost 200, whereas, we are expecting clear weather. Tobacco use again rising very rapidly, especially smokeless tobacco. So all these things are really alcohol misuse, one of the major factors. So really affecting the heart health of our country. And the main problem is there is a lack of screening, awareness, lack of primary prevention. Most of Indian healthcare is now concentrated around curative sick care with large hospitals, cath labs, cardiologists. But what will promote use of more technology to work on preventing heart disease is something that I really look forward to listening to on today's panel. What How can we make it reach everyone? How can we use telecardiology? How can we use wearables? How can we use AI based risk prediction tools to make sure that we identify the people at risk early and make sure that we prevent heart attacks from happening rather than taking curative steps once the heart attack has already happened. So what we must do is build bridges between innovation and access and ensuring that digital divide bridges the healthcare divide instead of widening it further. We know that 80% of premature heart disease is preventable through lifestyle changes, regular screening, and early intervention. So we must empower primary care systems to handle these cardiovascular, especially in rural and urban areas, and must go from episodic to continuous care. What we really should move away from is the old model of treating heart attacks to a new model of lifelong cardiovascular health management, integrating diet, mental health, physical activity, and medication adherence. So I think what we must, at the end of today's panel, try to get together on and make a declaration on is to make sure that we have heart health as a part of every policy conversation, whether it be urban planning, whether it be food labeling, whether it be air quality, or whether it be school education or college education. If we can move towards that, I think we will have a great kickoff to our conversations, and I'm sure you will take it forward in the many more panels to come that you will hold, and we will have a good agenda and a paper coming out of it at the end of it. So thank you once again for having me here, and a very warm welcome to my co-panelists. And I'm really looking forward to listening to all the experts today on their thoughts on what we are going to do in the future.
Thank you so much, Dr. Bajaj, for such an insightful opening. Next, I welcome Dr. Sundeep Mishra, who will shed light on the rising prevalence of sudden cardiac arrest, particularly among younger populations. Dr. Mishra, the floor is yours. I hope you are able to share your screen.
Yeah. Hello, everybody. Let me try to share my screen. So thank you for having me here. And I think this is a very important area, sudden cardiac arrest. And let me discuss some of the important things about it. I showed you that all these people died of sudden cardiac death. And the reason for sudden cardiac death was different in all the three cases. It was MI for KK. For Michael Jackson, it was multiple drug intake leading to conduction abnormality. And for Ryan Shea, it was hypertrophic cardiomyopathy, a kind of idiopathic disease. So this was the heart. I showed the three systems. What we are focused on is the conduction system. And this is the conduction system. The impulse is starting from the SA node, going to AV node, and then distributing to both the ventricles. You can see now, ma'am, and this is the key thing. And as you can see on the left side, the impulse, when it comes, it goes to the AV node, and from AV node, it divides into two bundles. The left bundle supplies the left side of heart and the right bundle. And this is the normal, and what you see is ECG, which is normal. But when you go on the right side, what you see is a very chaotic kind of distribution. The reason for this chaotic distribution is this phenomena called as re-entry, because when there is an attack or anything, when there is a abnormality, conduction abnormality, then the circus kind of movement starts happening, and because of this, it creates kind of short circuit in the heart, and you see this phenomena of ventricular fibrillation, which leads to sudden cardiac death. So some of the facts about sudden cardiac arrest. Number one, as I already said, sudden cardiac arrest is not same as heart attack. It can also happen to very young, even healthy people. Most sudden cardiac events happen at home, but they can happen at workplace, during the time of marathon, and other places as well. There may be no warning signs at all. Most people don't survive sudden cardiac arrest. That is why it is called sudden cardiac death. Sudden cardiac arrest, not just because of heart attack, as I already said, could be because of other causes, other heart diseases like congenital hypertrophic cardiomyopathy, some drugs, even some neurological disorders. And in these cases, family history is a very important risk factor. Coming to the prevalence, sudden cardiac death accounts for every 1 out of all the 6 heart-related deaths in India. at more than 75 years of age, one adult dies out of 100 dies annually with sudden cardiac death. And coronary artery disease is the leading cause, but there can be other causes as well. In India, as Dr. Bajaj already told us, it tends to occur at a younger age, at least 10 years younger than West. Average age in Indians is 40 to 60 years. 2 out of 3 sudden cardiac death people are men, and 4 out of the 5 have at least one traditional risk factor like hypertension, previous myocardial infarction, etc. The problem is that lack of access to emergency medical services and public awareness contributes to a higher incidence of sudden cardiac death even in rural areas. The data from NCRB shows that nearly 60,000 sudden cardiac deaths occurred in year 2022, and more than half of them were because of heart attacks. So heart attacks indeed the most common cause of sudden cardiac death, but not all cases die of heart attack. So I think that is important to know. What happens is when there is abrupt loss of conduction, and then the heart function suddenly stops, or there is a stoppage of heart function, and then that leads to sudden collapse and loss of consciousness, and death happens unless immediate first aid is delivered. So what are the warning signs? Although, as I said, majority of the cases there are no warning signs, but some of them may have chest pain, shortness of breath, dizziness or lightheadedness, palpitations, fainting or near fainting. They might happen. The risk factors for sudden cardiac death, most common is coronary artery disease. As I said, more than 50% are due to heart attacks, but other like cardiomyopathy, like hypertrophic cardiomyopathy or dilated cardiomyopathy can also contribute. Other arrhythmias can happen. Family history is important, high blood pressure, and a lot of lifestyle factors are responsible for sudden cardiac death. As Dr. Bajaj already told us that because of the current environment and other lifestyle changes, the risk is high for developing sudden cardiac arrest. What do you do about it? The first aid is very important. Here we can say that time is life. If no first aid is offered in the first 8 hours, then brain and body starts dying, and after a certain time, then a complete death can happen. So what you can do is, we can deliver first aid, which can be immediately call the emergency service, and then give something called CPR, cardiopulmonary resuscitation, which is push hard and fast in the center of the chest at the rate of 120 compressions per minute. And also, if possible, if you have available, use automated external defibrillator. Many times in the airports and many other public places, they implant these AEDs, which are very easy to use. But if possible, then when the medical aid comes, then advanced cardiac life support is also offered, and there may be reasons for long-term care as well. Now, important thing about deaths related to sudden cardiac death. As I said, that the death is rather more common outcome in sudden cardiac death, and it leads to death if not treated immediately, with the death rate reaching near 100%. So this is a very deadly situation. Also, the second important thing is that we have to keep in mind the time. Without treatment, death occurs within 6 to 10 minutes. Brain damage starts happening within 4 to 6 minutes. And so, as I discussed, survival without treatment, the survival drops 10% every minute. So every minute we lose in offering the first aid, 10% people will die. And as I said, if it is never offered, then the survival chances are near zero. With CPR, the chances of surviving double or even triple. With defibrillation, this is the basically therapy of choice. And if immediate CPR and AED is offered, you may be able to save 70% of these individuals, which would otherwise die 100% of the cases. But the important thing is, time is muscle, time is life, and you need to be aware of this time that is taken to offer the first aid. So to summarize, without immediate treatment, sudden death is almost always fatal. Immediate and rapid response with CPR and defibrillation is critical. In India, the rate of offering CPR or AED is very low, less than 2%. Even worldwide in advanced countries also, it is still under 30%. So I think here is the need for something to do, and so that will be, I think, good part of our discussion. Thank you so much for your kind attention.
Thank you so much, Dr. Sundeep. for giving us insights for that compelling perspective. To invite Dr. Shamit to tell us more about how to manage sudden cardiac arrest and resuscitation best practices. Let's welcome Dr. Shamit. Dr. Shamit, over to you.
Good afternoon, everyone. As Dr. Sundeep Mishra has already highlighted a lot about sudden cardiac arrest and sudden cardiac death. I'll be talking about the management of sudden cardiac arrest and how to resuscitate. The most important scenario in sudden cardiac arrest comes when the patient or the person suffering from it is out of the hospital. And out of hospital cardiac arrest constitute most of the patients coming to the hospital, and time is of essence in such a scenario. So whenever we see a patient is becoming unresponsive, the first and foremost thing we need to check is whether the scene safety is there or not. If the scene safety is there, then we should assess whether the patient is responsive, unresponsive. We should activate the emergency response system, or we should tell a bystander to get an ambulance. Next, we need to check the pulse of that patient, carotid artery, and that should take less than 10 seconds to do it. If we assess carotid artery is not there, simultaneously we can see whether the patient is breathing or not. And in case of a gasping like respiration or no breathing, we should immediately start with the CPR. Now, the CPR constitutes a very important part in the resuscitation of a patient with cardiac arrest. We should always go for a good quality CPR. That is, the rate should be around 100 to 120 per minute. The depth of the CPR should be at least 2 inches, and we should give adequate time for the chest to recoil. We should continue the CPR, and every 2 minutes, if we have a help, we should change the CPR. Every 30 CPR, every 30 cardiac CPR, we should give 2 breaths. So every 2 minutes, we should change the CPR, and we should continue like that. In case we have a AED, we should immediately apply the AED or defibrillator. Check whether the patient is having a shockable rhythm or not. Shockable rhythms are like VT, ventricular tachycardia, or ventricular fibrillation. If the patient is having a shockable rhythm, we should immediately defibrillate the patient. Upon arrival of the help or the ambulance, we should then shift the patient for a higher center or a definitive medical care. Now, the definitive medical care will involve the circulation, airway, breathing. We should ensure a patient is having a IV access. In case IV access is there, we should start giving drugs like epinephrine if the patient is still in sudden cardiac arrest. And in case there is no definitive airway achieved till that time, we should go for a definitive airway in the form of an endotracheal tube or a supraglottic airway device. Now, after the initial resuscitation, that was in the form of a CPR and that was in the form of a AED, we should go for a stabilization phase. In the stabilization phase, we should assess briefly what was the history of the patient. In case we know physical examination, we should send the labs and all, and simultaneously we should, if the patient is fluid responsive or like we are not anticipating a pulmonary edema on physical examination, we should give some fluid to the patient in the form of 1 to 2 liter of crystalloid can be given. And in case still BP is not being maintained, we can start with vasopressors. The first vasopressor normally we start with is norepinephrine, and vasopressin can also be started. Dopamine is slightly not preferred as compared to these vasopressors in terms of their arrhythmia potential. Once we have looked at the circulation, then we look at the airway and breathing. The target is to maintain a normal oxygenation level of more than 95% and a normal carbon dioxide level. EtCO2 level should be around 35 to 45. In case hyperventilation is detrimental for the patient, so during resuscitation we should avoid hyperventilating the patient, as that will cause cerebral vasoconstriction and the neurological outcomes can be hampered with that. So hyperventilation should be avoided in such patients. While the team is going for this resuscitation and stabilization of the patient, which is important to prevent a re-arrest, we should always focus on the reversible causes of the cardiac arrest. There is a good mnemonic by American Heart Association in the form of 5H and 5T. 5H stands for hypovolemia, hypoxia, hypokalemia, hyperkalemia, hypothermia, and 5T for cardiac tamponade and coronary thrombosis, pulmonary artery thrombosis, toxins, or tension pneumothorax. So these are the potential reversible causes. These causes can happen because of many different disease entities, but we need to identify the reversible causes. Then that will help us a lot in stabilizing the patient. Once we have done that, then the second important part comes is the prevention of the brain injury. For that, after resuscitation, we need to assess how the patient is responding. Is there any motor response or not? Reflexes are there or not? In case it is there, neurological outcome is good. In case these motor response is not there or reflexes are not there, sometimes prognosis is dismal in terms of neurological outcome, but then also we should not lose hope. We should go for a EEG to rule out non-convulsive status epilepticus in this patient. We should see for non-convulsive status epilepticus in this patient, and if it is there, anti-epileptics need to be given. Second is the temperature management in such patients. We need to keep temperature of around 37 or 36 degrees in such patients. Normothermia or slightly lesser temperature helps in a neurological recovery in such patients. Normothermia of 36 to 37 we can achieve by giving bolus cold salines. We can achieve that by putting in cold blankets. That can be done, and monitoring of the temperature is also important. Subsequently, along with this, we need to prognosticate the family also regarding the potential outcome of such patients. In all such patients who have undergone a cardiac arrest, subsequently resuscitation, we need to keep in mind that the neurological outcome we should not just govern by the initial presentation. We need to wait for around 72 hours, and then only we should prognosticate the family, see whether the patient is having a good neurological outcome or not. We should also tell the family regarding what was the cause of arrest and what are the chances of it. So these are the major, if we conceptualize the brief, these are the basic resuscitative measures we need to encompass. Once the patient is in ICU, then the general critical care principles need to be applied in the form of ventilator-associated pneumonia prevention, feeding, analgesia, sedation, thromboprophylaxis, head and elevation, ulcer prophylaxis. These need to be maintained. So again, to sum up my presentation, important factor in this is to educate the bystanders, educate our general population, need to undergo a BLS training. BLS training is very simple, having 6 or 7 steps. Immediate cardiac resuscitation effort by a bystander can markedly change the outcome of the patient, and 20 to 40% of the patient coming to the hospital out of the hospital cardiac arrest can go out alive and have a good life subsequently.
Thank you so much, Dr. Shamit. That was a valuable look into the emergency response. Thank you so much for this. I'll just check it at back end, and meanwhile, I would like to, just due to the paucity of time, I would like to invite our next speaker. We have Dr. Rajay Narain with us. Now let's zoom out a bit and look at the broader challenge, the overarching cardio-renal metabolic tsunami. So we are joined by Dr. Rajay Narain, a global expert in this domain. Dr. Narain.
Perfect. Thank you so much. Thank you to the Cygnus family for inviting me for this webinar. Can I start, Ms. Chawla?
Please, sir.
Yeah. Thank you so much to the Cygnus family and the team to invite me to this webinar. Thank you. It's a great pleasure to be here. So I'm a heart failure cardiologist with special expertise in cardio-renal metabolic medicine. I've set up UK's first cardio-renal metabolic clinic in the NHS. And I'm also the advisor for government of Ukraine and Ireland, and where we are setting up more cardio-renal metabolic clinics. My topic is talking about the overarching burden of cardio-renal metabolic, a tsunami of cases that we are going to see in months and years to come. So before I go into my details of my talk, but it will be very important for us to know about and learn about the global burden disease. So if you look at this disease database, this is the database that sits with Salim Yusuf at Canada University Hospital. So Salim Yusuf has the database for all the causes of death, the global burden of disease from around the world, from 193 countries. And if you look at this list, this is heart disease sitting at number 1, and in 20 years time, heart disease will still be number 1. But the interesting thing to look from here is that kidney disease, diabetes are going to be in the top 5-10 killers globally. So if you look at my list on the right, you can see that heart, kidney, diabetes, so cardio-renal metabolic are going to be in the top 5-10 causes of death globally as a non-communicable disease. And that is where 30 to 40% of causes of death are happening around the world. Looking at some of the numbers for heart disease, there are almost about 8 million people as in 2025 suffering from heart disease. The numbers are multiplying every hour, every minute, and especially in some of the developing countries of the world where again the impact of heart disease is taking its toll. If you look at some of those numbers, which was projected at 1990 was 2.26 million cardiovascular deaths in India. It was almost about 5 million plus in 2020. These are some of the states in India where there again increased prevalence of cardiovascular disease. In Kerala and Punjab, it was mainly related to alcohol intake. In Tamil Nadu, it was related to smoke, and again increased number of smokers. So again, these are interesting. I was not aware when I was doing some search, and I was surprised to see these numbers in Kerala, Punjab, and Tamil Nadu that they've got the highest number of cardiovascular deaths in India. But more importantly, it is, as Dr. Mishra mentioned, that sudden cardiac death, cardiac arrest that we are seeing happening in India is because of a lot of other reasons apart from heart attack, because everything in India unfortunately is classed as a heart attack when it is not a heart attack. And the reason for that is that we don't have a proper database in India. In the UK, we have a database at every hospital where all sudden cardiac deaths, sudden cardiac arrests happening between the ages of 14 to 35, they undergo a post-mortem. A cardiac biopsy is required to tell us what is the cause of death. And these are some of those causes of death where Professor Mishra was mentioning about hypertrophic cardiomyopathies, ion channelopathies, infiltrative cardiomyopathies, other coronary artery anomalies. So these are some of those inherited heart conditions that we pick up from our previous generations. So these are some of those defective genes that pass from one generation to another. They can sometimes skip the generation, but it is very important to identify the cause of death in every young individual because they may be having some of those defective genes which we can identify and prevent sudden cardiac death happening in the family members in the future. But unfortunately in India, we don't have any database for any of these sudden cardiac deaths happening, and that is what is required in India, apart from obviously the CPR and BLS support that is very, very important. But on top of that, I think cardiac biopsy, cardiac pathology is something that we need to really work in India. Because if you look at countries like Italy had one of the highest number of sudden cardiac deaths in India. Almost majority of the deaths in Europe were happening in Italy. And they started a screening program where they were doing a 12-lead ECG, a physical examination, and almost 60-70% of those deaths happening in Italy where they were able to identify both those ECG and physical examination. So Italy again has shown as to how implementing a national program of screening in young cardiac deaths can really save those lives. The prevalence, the incidence of sudden cardiac death in Italy has gone down by 80% in the last 7 years because of all these screenings. Majority of these problems, whether it be Brugada, ARVC, cardiomyopathies, they can be picked up just by an ECG and physical examination, and in some cases an echocardiogram. Some of these tests will require MRI and cardiac CT scans. But the majority of these problems like HOCM, Brugada, ARVC, all those can be picked up in 60-70% of those cases by just doing an ECG. Looking at diabetes, we know the numbers are growing massively around the world. Diabetes, again, India is now considered as the diabetes capital of the world. We were aware that in 2045, we'll possibly have about 700 to 800 million patients of diabetes globally. So this was the projection from the WHO 7 years ago, that in 2045 we'll have almost like 783 million patients with diabetes. Again, these numbers are more in low and income countries like India. But this is the database, this is the paper that has been published by the WHO a couple of months ago on the World Diabetes Day, that we have already crossed 800 million patients of diabetes around the world. So again, we are already reaching 800 million. We were supposed to reach 800 million in 2050. We're in 2025. So 25 years ahead of time, we have already reached 800 million patients of diabetes. As I said, that India is now capital of diabetes. We have already seen, and we are going to see, in fact, 68% increase in patients with diabetes in the next 10 to 15 years. So we are already reaching almost like 101 million. This is the national database numbers that has come from the ICMR. As you can see that these numbers are quite big, quite huge already. And that is where we need to focus. I think the need of the hour is to try and focus on cardio-renal metabolic, because we are going to see a tsunami of these cases in India in the months and years to come. These are some of the numbers, again, looking at the CKD numbers globally, almost like 850 million. Some of the papers, publications in India suggest that the number of CKD again can vary from anywhere from 5% to 30%. So almost like 10 to 15% of India's population is likely to suffer from chronic kidney disease in the next 4 to 5 years. So cardio-renal metabolic, why is this important? Why is there so much of focus there? Why is there so many of drugs coming out on a regular basis? If you look at this chart, which talks about all those metabolic pathologies that start in your body, like hyperglycemia, insulin resistance, sympathetic nervous system activation, all those problems, they affect your heart, because that leads to myocardial disorders, systolic diastolic dysfunction, reactive fibrosis, LVH, arteriosclerosis. So all those inflammatory changes that lead to changes in the heart, and at the same time they also affect the heart, because in the kidneys it leads to glomerular hyperfiltration, hypertension, hypertrophy in the kidney side of things. So again, cardio-renal metabolic is kind of a paradigm where all these problems are linked to each other. If you have a patient with diabetes, you are likely to see at least 30 to 40% of those diabetes patients having heart condition, and at least another 30-40% having some degree of chronic kidney disease. On top of these non-communicable disease, there are lots of other problems like non-communicable disease, climate change and health. There's a paper that has been published today in India that air pollution is responsible for almost about 30 to 40% of cardiovascular deaths in India. So this was published today in one of the big journals in India. So again, pollution and climate change is one of the main changes that we are seeing as responsible for one of those big burden for non-communicable disease. Mental health crisis post-pandemic has become a big thing. Drug hesitancy, misinformation, social media misinformation is another challenge. Health inequalities does exist around the world, even in countries like UK. If you are in north of London, the kind of heart failure management and the treatment that you get is different from South London, where I live. Because in South London, you get all the 4 pillars for heart failure. In North London, you will not get all those 4 pillars, because again, there is inequalities in the way the healthcare system works. There are emerging infectious disease pandemic that we have already seen recently. Antimicrobial resistance is another huge, big challenge that around the world it is becoming one of the major health issues that we have to address. And again, there are some pandemics and bioterrorism risk. So these are some of those problems which are responsible for increased burden of disease in India, complications from all the cardio-renal metabolic problems or other non-communicable disease. There's lack of screening. There's a database that has been published by WHO recently suggesting that almost 70% of the targets in non-communicable disease around the world, including countries like Europe or India, are likely to be missed because we are not screening enough. The healthcare system limitation is there. There are socioeconomic disparities that I talked about. So what are the challenges? How are we going to address this? Strengthening the healthcare system, community intervention, regulating the misinformation, AI-driven systems, training healthcare providers, enhancing the public health education. So all these strategies have to be brought in place to address the healthcare problems, especially in developing countries. Like we are now one of the most populous country in the world, and these are some of those problems that we are facing on a regular basis as a healthcare professional. I think time has now come to bring in all of these solutions together as a holistic approach and address those problems. So what we need is have a combined holistic approach in managing all those non-communicable disease, the big problem that we see in India, especially the non-communicable disease. Climate change needs to be addressed not just by general public, but government also has to put in a lot of effort and money to address these challenges. Technology inclusion is important. We are now using artificial intelligence in cardiology and radiology across Europe. So that also will play a very important role. But more importantly, a global partnership is required to strengthen the healthcare system so that all these disease burden, especially non-communicable, especially the cardio-renal metabolic, can be addressed more effectively. Thank you so much, and I'll be very happy to take some questions at the end.
Thank you, Dr. Narain, for sounding the alarm and laying out the challenges ahead. Thank you so much. We have many more questions. So before that, I would like to invite Dr. Bhawani to take us up with the key risks and symptoms of sudden cardiac death. Over to you, Dr. Bhawani.
Thank you, Vandana. Hopefully this time I am able to share my presentation.
Yeah.
We can hear you, Dr. Bhawani. Carry on. We can hear you.
We can hear you. Yeah. Okay, so maybe it will take some time. You can start, sir. You can start.
Okay. So, sudden cardiac death in India, epidemiology, causes and challenges. It has been defined as an unexpected death due to cardiac causes that occurs within 1 hour of the symptom onset, if it is witnessed, or within 24 hours if it has not been witnessed in a person with or without known any heart disease. So it is typically caused by sudden loss of heart function, which is also known as cardiac arrest. So certain differences between sudden cardiac death and cardiac arrest, very misconceptions particularly among the general population. So in sudden cardiac death, there is sudden irreversible cessation of all the biological functions as a consequence of cardiac arrest. So it is basically a sequelae of cardiac arrest, and there is no point of return. The patient has already been pronounced clinically dead. Whereas in cardiac arrest, there is abrupt cessation of cardiac mechanical function, which leads to death in the absence of reversible procedures which are employed, such as the ACLS protocol or use of CPR or use of automated external defibrillators. So what is the difference between sudden cardiac arrest and a heart attack, which sir has already explained? So in case of sudden cardiac arrest, the patient is unresponsive, is not breathing normally, the heart has stopped, and in such patient they do need immediate CPR or AED so that they can be revived. Whereas in heart attack victims, the patients are responsive most of the time, they are breathing, the heart is beating, and they doesn't need CPR and AED. But one very important thing is that sudden cardiac arrest and sudden cardiac death, they can be a manifestation of heart attack. So heart attack patients can present like this. So sometimes, many times a patient, they don't have any prior risk factors, or they are not aware of it, but they present to the hospital for the first time as a sudden cardiac arrest or a sudden cardiac death, and on evaluation they are found to be having myocardial infarctions. So coming to the epidemiology and statistics, the global burden, as already discussed by Dr. Rajay, 5 to 10% of all the natural deaths is being accounted for by the sudden cardiac death. If we talk about the out-of-hospital cardiac arrest survival, the survival is very, very dismal. It is less than 10%. And mind it, this data is from the Western countries. So in India, where we don't have that level of health infrastructure, AED is not available at every nooks and corner, and even we don't have any onlooker or bystander who are trained in doing a CPR. So we can imagine what's our status in case of out-of-hospital cardiac arrest survival in India. But when immediate CPR and AED is employed in such situations, we can increase the survival up to 50%. Regarding the age and gender, again, the male gender is at disadvantage here. They have 2 to 3 times higher risk of sudden cardiac death as compared to women, and the peak incidence is in between 45 to 75 years of age. So, regarding the scene in India, the estimated annual sudden cardiac death is around 1.3 to 1.5 million, which accounts for almost 7 to 10% of the total deaths. And as we know that India has already become a diabetic capital of the world, and we are at the cusp of being the cardiovascular disease capital. So, and the one very unique factor which is very unique to India is occurrence of coronary artery disease, particularly in the younger age group, that is less than 50 years. And we do see in our practice daily that even 25 years of age, 27 years of age, young guys, they are coming with acute MI. If we see 25% of the sudden cardiac cases, they occur in less than 50 years of age group in India. Whereas if we compare it with our Western cohort, it is in less than 10%, seen in less than 50 years of age. In athlete and young adults, there has been an increasing reports of sudden cardiac death during exercise and marathon. And if we look into the urban and rural divide, in urban population, due to the lifestyle factors, the sudden cardiac death is more related to the coronary artery disease, whereas in the rural population, it is most likely due to undiagnosed cardiomyopathies or limited access to the healthcare. So what are the other causes which are very unique or maybe said that which are common causes of sudden cardiac death in India? Coronary artery disease remains the at the top. So early onset, as I already said, and we know that it occurs a decade earlier in the Indian or Asian population. And one of the risk factor which has been attributed is the 9p21 variant, and also lifestyle factors like diabetes and smoking. The other factor is Asian Indian phenotype, where we do have higher visceral fat, which is known to increase or secrete inflammatory cytokinins, which has got a very adverse effect on our endovascular health. And we Indians also have more diffuse nature of atherosclerotic disease as compared to vis-a-vis focal blockages. The other factors like hypertrophic cardiomyopathy, Brugada syndrome, long QT syndrome, particularly in the Indian population, LQT2 has been considered to be more common for sudden cardiac death, and dilated cardiomyopathy. And Indian population, this TTN truncation, which is basically a titin protein, titin gene, which is one of the largest gene of the human genome, and it encodes for the titin protein. So a mutation in this titin protein has been found in cases of Indian population with dilated cardiomyopathy. So other risk factor we know, rheumatic heart disease. I would say it is in decline even in India, but still quite a number of cases are seen in the rural population. As Dr. Rajay already told us about the air pollution, so particulate matter 2.5 has been linked to increased myocardial infarction and sudden cardiac death risk. So I would just like to say a few words about the 9p21 genetic variant. I think this is very, very important, particularly with its role in sudden cardiac death in India. So it is basically, it has been considered as a strongest non-lipid genetic risk factor for coronary artery disease and myocardial infarction. And the mechanism by which it leads to is by doing a vascular inflammation, where it accelerates the atherosclerosis. It can lead to plaque rupture, acute coronary artery occlusions, and leading to ventricular fibrillation, which can precipitate sudden cardiac death. So why is it this 9p21 variant is so important in India? It has got a very high prevalence, 2 to 3 times higher frequency is seen in the Indian population. It leads to early coronary artery disease, contributes to premature heart attacks in less than 50 years of age group. And in 2003 study by the Indian Council of Medical Research, they found that 40% of the young Indian sudden cardiac death cases with CAD had this 9p21 variant, and such patients, they often are asymptomatic before the sudden collapse. So who should get tested for this? If there is a family history of sudden cardiac death, and if there is a family history of premature coronary artery disease, unexplained syncope, such patients should always try to get this tested. And if they are positive for this, for instance, what should be done? So they have the ICMR have proposed that such patients, they should be having a very aggressive LDL control, lifestyle changes such as no smoking, exercise, and calcium scoring and CT angiography at a younger age. In the age of 30 to 40 years of age group, they should be subjected to these investigations. So regarding 9p21, if your family has unexplained sudden cardiac death, one should demand for this testing, as it is cheaper than a funeral. So these are again some of the risk factors as per the age group. We know, and already has been discussed, in between the 20 to 30 years of age group, it is basically myocarditis, hypertrophic cardiomyopathy, long QT and short QT syndrome, arrhythmogenic right ventricular dysplasia, where there is fibrogenic or fibrofatty degeneration or replacement of the myocardial tissue, leading to arrhythmogenic substrates and sudden cardiac arrest and death. So these are the reversible causes. So whenever we are attending to such patients who have come with sudden cardiac arrest, sometimes they don't have any coronary artery disease. So we should be keeping in mind all these reversible causes, which treated promptly can lead to revival of such patients. So which includes hypovolemia, hypoxia, hypothermia, hypo or hyperkalemia, cardiac tamponade, toxins, and of course coronary artery thrombosis and pulmonary thromboembolism if it is a massive one. Just a few words about the mechanism. So what is the underlying mechanism which leads to sudden cardiac death? So in most of the cases, 80% of the cases, it is the ventricular fibrillation. So Sir Mishra sir has already pointed out that it is a very chaotic rhythm where there is no effective or effectual myocardial contraction. So that leads to compromised blood flow to the vital organs and to the brain, and leads to death within 3 to 5 minutes if all the resuscitative measures such as CPR or ACLS protocol mechanisms and AED is not employed. So beside ventricular fibrillation, pulseless ventricular tachycardia, asystole, and pulseless electrical activity where there is no electrical activity but no mechanical contraction. So these are the underlying causes which ultimately leads to sudden cardiac death. So again, these are risk factors which can be categorized into non-modifiable and modifiable risk factors. So certain prodromes which should be taken care of and which one should be wary of. So preceding symptoms, it occurs in more than 50% of the cases, which can be chest pain, which can be shortness of breath, palpitation, unexplained fainting or syncope, and extreme degree of fatigue. So coming to the prevention of sudden cardiac death, before the sudden cardiac death occurs, so which is primary prevention. So lifestyle modification cannot be overstressed. We know that quitting smoking, controlling the blood pressure, cholesterol and diabetes is very important. Regular exercise is very important. We Indians are not very comfortable with it. In one of the studies, as per the World Health Organization, which recommends that 150 minutes of exercise should be done at least per week, but they found that only 10%, less than 10% of the Indians stuck to this recommendation. Now, regarding the medications which are known to prevent beta blockers and which are known to prolong the survival, or they have the survival benefit, beta blockers, ACE inhibitors and statins. And of course the devices, implantable ICDs, AICDs, for high risk patients, particularly those with severe LV dysfunctions, those which have the history of ventricular tachycardia and ventricular fibrillation. Nowadays they have clubbed this LVEF of less than 35% with late gadolinium enhancement MRI, which also gives you an idea of the extent of fibrosis. So increased degree of fibrosis associated with severe degree of LV dysfunctions calls for an AICD implantations. So secondary prevention, we already know if a patient has survived a cardiac arrest, class 1 recommendation is AICD implantation. And of course, if the patient has survived the cardiac arrest, then we should evaluate the patient for the coronary artery involvement, and if there is critical degree of stenosis, then they should be undergoing coronary artery disease stenting, coronary artery stenting. And in case of scar-related ventricular tachycardias or ventricular fibrillations, ablation is definitely a choice of treatment. So management of cardiac arrest, sir has already discussed it. In case of witnessed cardiac arrest, we should always look for immediate help, start CPR as soon as possible. Use of AED is very, very important, because use of shock or AED within 3 to 5 minutes increases the survival to 50 to 70%, and without it, we know out of hospital cardiac arrest survival is less than 10%. So post resuscitation care, of course, therapeutic hypothermia, cardiac catheterization, and long-term ICD placement. So this is how the defibrillation is, why so it is so important. So every minute counts. If we see at the first minute, the survival goes up to 90%, but with every increasing minute, by 9th minute, the survival is up to 10%, even less than that. So what is the future direction we are looking at it? Nowadays, artificial intelligence is very much in vogue. So a lot of devices and a lot of diagnostic tools have been incorporated with these AI-based tools. So AI-based ECG analysis, which can detect silent atrial fibrillation and patients at CAD risk. We have now wearable defibrillators, and of course gene therapy for inherited arrhythmias is being talked about and also is being researched about. So conclusion, it's a major public health problem, and awareness, prevention and rapid response can save life. So we should know the risk factor, we should recognize the warning symptoms, we should learn to have know CPR and know how to use the AED, particularly the general public, they should be made aware of it, and we should advocate for heart healthy lifestyles. So time is muscle and every second counts in SCD. Thank you so much, sir.
Thank you so much, Dr. Bhawani, for giving such a detailed presentation and making us aware about the uses of AEDs and the timing when sudden cardiac arrest is there. With this, I would like to thank all the speakers. Dr. Bhandari is stuck up with some emergency surgery, so he is not able to join us. I'll take few questions before we go ahead. I can see many questions are already answered through the presentation of Dr. Sundeep, Dr. Rajay, and Dr. Bhawani as well as Dr. Shamit. But still, I feel a few questions before we wrap up would give more clarity to the audience. And let's start by directing the first question to Dr. Narain. The question is, how interconnected are heart, kidney, and metabolic diseases, and why is it crucial to adopt a unified approach? And what socio-economic factors are driving cardio-renal metabolic tsunami, and how should public health policy adapt it? Over to
Can
you.
you hear me, Dr. Chawla? Can you hear me?
Thank you. Yeah, we can hear you.
Perfect. Thank you so much. It's a fantastic question. I think there are three parts to the question. To answer your first question, I think there is a lot of evidence now that cardio-renal metabolic are interconnected, and the main driving force is the inflammation. As I mentioned in my slide and my presentation, that all those pathological system that play in when you have like sympathetic nervous system activation, inflammation, increased discharge of inflammatory pathways in the body, that leads to a lot of changes in the heart, lot of changes in the kidney, and that is how this is are kind of interrelated. Number one. Number two, we have already proved with the proof of concept when we started our first cardiometabolic clinic in 2020. That is almost like 5 years now, and we are now setting up at least 11 of those cardio-renal metabolic clinics across UK. That managing these complex patients, because all of these patients that I mentioned about, the complex cardiac, renal, metabolic patients, they all come with different kinds of problems, complications, challenges, and having three experts together managing these patients together. For example, if somebody has heart problem, they don't need to just go to a heart clinic, and if they've got diabetes, they have to go to a diabetes clinic or a kidney clinic, bringing all the experts together in one clinic. And that is what we have done. We've got a cardiologist, we've got an endocrinologist, we've got a nephrologist, all three sitting in the same setting, same clinic, managing all these complex patients, making a unanimous plan for this patient long term. And that will be very much required long term, I think, for all these patients, complex patients with heart, kidney, and diabetes. As I said, that this is emerging as one of the biggest health challenges that we are seeing in around the world, not only in UK, Europe, but around the world, especially in countries like India, because India is already considered to be a diabetes capital of the world. We are seeing a big number of cases with kidney problems. Heart is already established problem, as Dr. Bhawani mentioned and Dr. Mishra mentioned earlier. So I think there is a need for cardio-renal metabolic platforms, organizations, hospitals, institutions delivering all these three as a holistic approach together. And that is why, because most of these heart failure patients, for example, only have got 5 to 7 years chance of survival if they're not given the 4 pillars for heart failure. But if you have an expert who can manage your heart, kidney, and diabetes together in one setting, that is how we are going to see things getting better and better for the patients long term. Talking about some of those socioeconomic challenges, I think it all depends on the cases of one is how much funding the government is using, the GDP amount of the GDP, and that is being given to the health. Depending on where you are born, if you are born in obviously in London and born in Sudan and born in India, it depends where you are born. It is also dependent on your education, depending on your food insecurity. So there are lots of other socioeconomic challenges that play a very important role. But I think most important, we are in fact looking at a program yesterday night and on BBC that there are more than 1.5 million patients with different medical health conditions who are suffering because of the ongoing war in Sudan, for example. I'm already working with government of Ukraine, and I can see that there are hundreds and thousands of patients with obesity, diabetes, kidney disease who are not getting even basic treatment because there's such a challenging situation. So it's just a case of bad lottery, I would say, that it depends where you are born. But again, I think, as Dr. Shankar mentioned, that there is a need for bigger, larger awareness in countries like India, where heart, kidney, diabetes is one of the biggest challenges that we are facing. One, public awareness, and two, more funding has to come from the government to strengthen the healthcare system.
Thank you so much, Dr. Rajay, for giving us such wonderful insights and awareness about the overarching cardio-renal metabolic tsunami. The next question is from Dr. Sundeep Mishra. Are there new clinical markers or diagnostic tools being developed to predict the likelihood of sudden cardiac arrest? Over to you, sir.
Yeah, so I think very good question, and I think we are in the era of artificial intelligence, And now there are artificial intelligence based tools that can sort of based on ECGs, they can predict that this person is going to develop certain cardiac arrest. There were some tools developed earlier, RR interval variation, etc. And now there are a lot of whole set of tools available on ECG. Also, there are tools available for the metabolic and immune profiles of the individual, and artificial intelligence based on those metabolic, as Dr. Narain already told us, that metabolic syndromes are very closely related with not only diabetes but even cardiac and other lifestyle diseases. And so there's work on these tools looking at metabolic and immune parameters to predict certain cardiac arrest. Then the third thing is that there are now a lot of biomarkers, newer ones, which are being developed, which can predict blood-based like secretonurin and 4-beta hydroxy cholesterol, and a lot of proteomic and lipid things. Now also there are certain smart watches that are available which look at your various parameters, and they can give you an alarm or warning sign that something is impending. So people are developing those kind of algorithms, also smart watch based. And then there has been some work on genetic markers, like looking at some ion channels, genetic markers to predict who will develop certain cardiac arrest. So there are a lot of work going. Particularly exciting ones is artificial intelligence, ECG based, and metabolic or blood markers based. And beyond that, of course, some new biomarkers are available.
Thank you, Dr. Sundeep. Now the next question is for Dr. Shamit. How important is CPR and AED training among non-medical personnel, and what steps can be taken to popularize it? Over to you, Dr.
Very
Shamit.
essential. It is very essential for the layman to be aware of how to do a CPR and how to use a AED. As of now, if we go across the society, hardly any person is trained in the same. But then it has to be taken up by maybe the private organizations and by the government also, to train each and every person in the basic life support training, and that is very simple. Only 5 to 6 important steps are there. But the government initiative of Swachh Bharat was taken and propagated, I think, the same way. It should be taken as a life-saving mission by the government also and by the private healthcare also.
Thank you, Dr. Shamit. And before we wrap up, the last question is for Dr. Bhawani. How effective are current screening programs in identifying early symptoms and intervening before a cardiac event? Over to you, sir.
Frankly speaking, though we are facing this epidemic of cardiovascular disease and sudden cardiac death, the screening for prevention of cardiovascular diseases and screening for prevention of sudden cardiac still remains very dismal in our country. I'll just like to give an example of a national program which was launched in 2010 by the Indian government. It was a national program for control of cancer, diabetes, cardiovascular diseases, and stroke. So if you look at this program, though it was launched in 2010, what does it do? The target audience were adults with more than or equal to 30 years of age, and they did only basic tests like blood sugar, BP measuring, doing a basic lipid profile, and the reach is only to the up to 10 to 15% of the population which are at risk. So such programs which are being backed by the Indian government, they don't have a very deep entry into the rural population as well. And such programs which are backed by the Indian government, they don't have very basic investigations such as like an ECG or echo, which can be done, which can at least give you some sort of idea about the cardiac status of the patient. So I would say, frankly, the whatever the screening systems we have, or it is really dismal, and more needs to be done, particularly in the era of the Ayushman Bharat, where we are seeing most of the patients who are coming to our hospital, they are having Ayushman card. But despite that, we as a doctor, we as a cardiologist are not able to do justice to our patients, because a number of procedures, a number of investigations, they are not included in Ayushman procedures. Like if we want to get a patient, particularly the poor patient who come from the villages, they are not able to afford a CT coronary angiography. They won't be able to afford a genetic screening test if we want to assess them for any certain cardiac death. So these tests, which are very basic, they should be incorporated into the government programs, and a lot needs to be done in this field.
Thank you so much, sir. I would request all the participants to turn on your cameras so capture your smiling faces towards the end of the session. And as we conclude this powerful and thought-provoking session, I want to sincerely thank each of our speakers for sharing their time and for taking out time from your busy schedule to give us such great knowledge. We hope today's discussion has not only informed you but also inspired action, whether in clinical practice, public health, or your personal well-being. And please stay connected for future sessions. Until next time, stay safe, stay heart healthy. Thank you and Jai Hind.
Thank you, sir.
Thank you, everyone.
Thank you.
And big thanks to all the speakers for taking out time from your busy schedule. Dr. Rajay has joined us from UK, and Dr. Sundeep from Moradabad, Dr. Bhawani from Kaithal, Dr. Shamit from Karnal. We are so thankful to you for such a wonderful session. Thank you so much, everyone. Namaskar.